it's so important to understand who the person is as a whole, what resources they have at home, what their beliefs are, what their status is at home as far as, who lives at home and who do they take care of and who takes care of them. Heard that your cousin passed away. I'm reaching out to you just to see, are you
Uh,
doing okay? You can be more proactive about reaching out and not waiting for them to show up in your exam room. And I think people appreciate that, just to say, I see you.
Welcome to the Counterweight Podcast. I am Doug Rogers, your host, and I'm excited to share these stories of vision, passion, and growth leadership in digital health. I am focused on speaking to and learning from founders, growth, and operational leaders across the healthcare space about their journeys and lessons learned. We believe that a majority of people join healthcare companies, technology companies, providers, healthcare systems, because they believe in the mission of improving lives of those around them. We will discuss with our guests their why for digital health. We will learn about success and challenges and what they learned from these events for themselves and for their teams. We will also discuss what tips and tricks these leaders use to help keep them positioned for success, as well as how they balance the tension between mission and margin. Join us each week for a new episode with our guests. You can find us on Apple Podcasts, Spotify, YouTube, and LinkedIn under the name The Counterweight. Subscribe, like, follow, and give us feedback as we go along. Now on to our show. Hello, this is the Counterweight Podcast. My name is Doug Rogers, and I'm joined by my co-host, Russell Stover, and we are extremely excited to welcome Dr. Jennifer Bacani McKinney to the pod. So for our audience, if you don't know her, you may have seen her at the Digital Health Day earlier in the fall of 25. She was a phenomenal panelist, but that's not her only accomplishment. She's a family practice doctor, runs the Fredonia Family Care Clinic in Fredonia, Kansas. She is a graduate of the University of Kansas, both for undergrad and for medical school. She interned at Via Christi for family medicine. She received the 2021 Rural Health Practitioner of the Year Award from the National Rural Health Association, the Early Career Achievement Award from the KU School of Medicine. She is also the Associate Dean for the Office of Rural Medical Education at the University of Kansas. She is the Wilson County Health Officer. That is sometimes a thankless job, but a very, very important job. We don't talk enough about public health, by the way, complete aside. And she is the founder of the Fredonia Medical Academy for high school students and the founder of the Remote Scribe Company that provides virtual scribes for providers all across the country. As an aside, any doctors listening, you need a virtual scribe. She is the person you need to reach out to. So that's a lot. I am just overwhelmed. I'm thankful for you to be here. Dr. McKinney, we're going to dive right in.
Yeah. So thank you, Doug. Thank you, Jen. This is such an honor. I actually had the privilege after seeing Jennifer at Digital Health KC Day. I reached out through an intermediary and was able to get connected and go and visit Fredonia, where Dr. McKinney practices. And it was an unbelievable experience for me. And it was really important for me to I was lucky enough to be able to experience the way that Jennifer practiced, the people at her practice, and some of the people that came to her practice, which I thought was really interesting. I've not spent a lot of time in rural health or rural communities recently. So I am so grateful for that opportunity. And I'm sure we'll talk more about that as we go through today. The question that I have that I want to start off with, which is near and dear and pertinent to this particular podcast, is, Jennifer, could you tell us something that is new that you've started doing with technology? Could be AI, doesn't have to be, in the past 24 months within your practice.
Sure. Of course, I have to start off by saying thank you. I'm really excited to be here. Thank you, Doug. Thank you, Russell. I always feel super cool when I get to talk about rural health and the stuff that we do. So thank you for sharing the stories of rural health. And it really means a lot to me to allow me to be here today with you guys. So Russell, as far as technology recently, I mean, there's just so much. It feels like that we're constantly bombarded. We have people coming into our office kind of telling us about things and maybe selling us stuff and there's so much to choose from. I think one of the biggest things that I have started using and my partners have started using in our practice is an AI product called Open Evidence. So a lot of what we what we used to do, of course, like everybody else, was search and look at papers and research and really make sure that we're looking at reputable sources. Luckily, this product is something where we can, just like any AI, we can literally just put in, what we're looking at. Just yesterday, I put it to open evidence a 72-year-old male with petechia on his legs that started 2 days ago and got, a big differential diagnosis of things I hadn't even thought of, which really was helpful for me in helping diagnose him. So it's been
Wow.
a real a game changer for us in our practice.
So Dr. McKinney, I'm curious. This is a little bit of a tangent. How do you feel like tools like that is going to change medical students in their training?
It's a great question because, I mean, at the heart of it all, we still have to learn everything we can possibly learn. And I can't even imagine. I've been out of practice, out of school for a little while now. And so I'm like
It's hard to believe.
like to I like to think when I'm talking to medical students that I'm like, I'm hip and cool, I'm young, but I'm not anymore. That's the reality. But I can't even imagine going to med school now and trying to learn everything that you have to learn. And it's impossible, truly impossible. So technology like this, AI like this, I think is going to be super important, super useful because we'll learn really obscure things that we'll probably never see in our careers, but if we do run across it in our careers, at least we have something to say, hey, don't forget about this one very, very rare condition that someone might have that you learned about in your first year of med school. And that will bring things to the forefront. So I think it's going to allow us to manage everything that we learned and help us to not forget and help us to recall some of the things that maybe, we don't see day to day. And it's going to be very important for us to manage the the endless knowledge that we have presented to us.
I was just going to ask. So, as you think about your population there in Fredonia, so for our listeners who are watching the video, she is in at the University of Kansas right now. So, sitting within the academic setting, she's going to go back to Fredonia, which is the population she serves. What is a common misconception that you would say people in urban settings have about health and care for populations that are in towns like Fredonia, in towns all across, whether it's Kansas, Missouri, Iowa, et cetera? What do people don't really, what do they really not understand around how health and care is delivered and impacts those communities?
Doug, I love this question. Thank you. Thank you for asking because I get a little bit passionate about this that when we're in a small town, when we're practicing, we're the only gig in town, right? So like you mentioned,
Yeah.
I'm a family doctor. I own Fredonia Family Care. I have great partners. But like we're in the clinic, we're also the hospitalist doctors, we're also the ER doctors, we're also the nursing home doctors, the assisted living doctors, like you mentioned, the county health officer, we do all the public health. We also, manage all the hospice stuff. If a baby, even though we don't deliver babies in our hospital, we deliver them if they show up because it's kind of rude if you don't. So we do what we have to do there. So to be a rural practicing physician is not for the weak of heart. So the thing that I always like to tell my urban colleagues is that by the time I'm calling you to ask for your help, it's because I've done everything humanly possible. My MRI machine is only there on Sundays, and I'm going to do everything Monday through Saturday to figure out what's wrong with the patient until the MRI machine gets there. You have ultrasound after 5 o'clock every single day because the tech goes home and they live 45 minutes away. So we have to have the best clinical knowledge, the best clinical experience possible. And we do everything possible to keep people in our hometown where they can be close to their families and we can take care of them and we can do all the tests rather than having them drive an hour and a half to Wichita or 2 hours to Kansas City. So when I'm calling and my urban colleagues are picking up the phone, whether it's here at KU Med or anywhere else, and when I'm calling and I'm saying I need your help, we really have exhausted everything we can possibly do. And that's to say, um, I don't ever want people on the urban side of things to think that we just don't know what we're doing here because
Yeah.
we work with the limited resources. We're very creative. We're very resilient. We're very resourceful with what we do have. And I would love for anybody who's in a big healthcare facility or an academic center to spend a day with us and see what we do in a day to really understand it. Every once in a while, the person who picks up the phone on the other line is like, well, did you try this? Did you already try this? Did you ask the patient about this? And I'm like,
Yeah. Yeah.
please don't do this. So I want people to understand like the work that we do here is unlike any other work. When we're in a rural setting, it's because it's the work that we have to do with the things that we have in front of us, and then we need our urban colleagues to take the baton when we're asking and understand the work that we've already done.
Yeah, I mean, you have to be very scrappy. And I'm curious, did you say that you only have an MRI machine on Sundays? Is
Oh
that what
yeah,
I heard you
yeah, yeah,
say? So,
yeah.
so how does that, what, is it not at the hospital full time? How does that work?
No, it's like a mobile MRI. So the truck comes, and usually on
Okay.
Saturday nights my minivan is parked in the way, and they tell me to move my minivan, and so so they're like, get out of the way. But so what happens is, like, most things that need an MRI besides a stroke, most things are like, a hurt knee or a shoulder or something like that, and they usually can wait. And what we can do in the meantime is, you know, rely on our physical exam skills, and we can usually get it right. Like, oh, your ACL is torn because I can tell the way your knee is moving right now. We don't need an MRI machine. What happens is you need an MRI to prove that you need surgery, or and have insurance pay for your surgery. They're not going to rely on me to say your ACL is torn. So most of the things we could do without an MRI machine.
That's incredible. I had no idea. Obviously, it kind of forces you to understand the very basic level of care that everyone as a provider should understand. But also, I just never knew that there was a mobile MRI machine. I didn't know that existed. That's amazing.
Yeah, drives all over the place.
Yeah, yeah, it's really incredible. Okay, so I've got some questions that I'm going to go through, and these were things that I really kind of compelled me based on our visit. It allowed me to really think about what does it mean to go into rural practice, and what does it mean to connect with your community in such a unique way. Healthcare is part of every community, but you can really sense the way that it aligns to the values of a community more when you're in a rural community, and you can really kind of grasp the scope of the. My first question to you is, why did you decide to go into family medicine and primary care?
Well, I would say that most of my childhood was spending time in the back of my dad's office. So he was a general surgeon in Fredonia, 47 years, just retired this last March.
Wow.
Yeah, and I mean, it's
Congratulations to him.
yes, really, really. Oh, he's served that community, given everything to that community, and it really is our home. And what I watched as I was, after school, I would sit in the back and watch TV and have snacks and whatever. But what you would see is that he would come to the back of the clinic and maybe put down a plate of cookies, and I'm like, oh, where'd those come from? Or like a blanket that somebody made specifically for me or one of my siblings, and I'm like, where are these things coming from? One time, a patient actually couldn't pay for their full surgery, so they gave my dad a goat. So that was back in the day, and I was super excited because I think I was like 5 or 6, and I was like, "Yeah, I have a pet goat. This is awesome."
Yeah.
And unfortunately, Peaches, that I named it Peaches, after about a week of me like playing with Peaches and feeding Peaches after school, Peaches disappeared, and I had to ask my dad where Peaches went, and he explained that Peaches went to the butcher, and I was like, okay, cool. And then I said, Mom, what's a butcher? Anyways, whole long story that my therapist knows about, but just kidding, just kidding. But the point of all that is that I saw the impact he was making on people that was just beyond, like checking in with them, doing their surgeries, grabbing their gallbladders, whatever it is. They had such an appreciation for him and what he did that they took time out of their lives to make cookies or, make a blanket for his children. And I started to realize, I would work in his office after school then. So I would help with billing, or I help with rooming patients, or help with transcription. And you just started to recognize what kind of impact he had in such a small town, and if he was not there, what would all these people be doing, and where would they get their health care, and where would they have to drive if they had to get health care? So now, even though he wasn't even though he's a general surgeon, he's kind of old school, like back in the 70s, so they kind of did a little bit of everything. And so what I saw was the primary care part of his practice, and that's what I fell in love with, and that's what I said, okay, this seems like the kind of doctor I want to be. And then, of course, when I went to med school, everything that I did, I loved. And I think that's the beauty of family medicine, is that you never have a dull moment. If I have 24 patients in a day, there are 24 different things that I'm dealing with, in that day. And you probably saw that, Russell, too. No two patients are
Yeah.
ever the same. And it's always a surprise when you walk in. The next door is like, what are we dealing with today? This is Interesting. But so I think for people who want the challenge, who want to kind of know a lot about a lot of things and really help people the best that they can without having to, ship them off to, a specialist for every little thing. I mean, that's where family medicine really appeals to me and a lot of people. And it's great. It keeps life exciting.
Yeah, I mean, you really, um, you get to, especially in a rural setting, you get to know these people. It's not like, and I know that there you can still get that whenever you're in an urban setting or in a suburban setting, but there's not a lot of options for folks if they want to receive healthcare. And so, in a way, it kind of forces this dynamic where you really have, in a lot of cases, probably pretty long relationships with some of these patients, right?
Mhm. Oh, absolutely. And I watch my dad. Can you imagine? There are some people that he has literally seen 47 years, and
Yeah.
I
Yeah.
mean, even me, I've been in practice now 16 years and just I've become that this is how I know I'm old. Like I've become that person that when I'm seeing, a senior in high school for their sports physical, I'm like, "Oh, I remember you when you were doing your preschool physical."
Yeah.
It's but how magical, right? Like how great to be able to do that. It makes me think of one family that my dad took care of this couple and they have I believe they have 8 children. I now take care of some of the children of that couple that my dad took care of, and I take care of their children, and then I also take care of their grandchildren. So that's like a 4 generation like situation there that my dad and I have been able to take care of this single family. And there's other examples like that, but I mean, how great! What other specialty, whatever other profession can you like watch an entire family and care for them generation after generation. It's the coolest thing, really.
Well, neither Russell or I are doctors, either in real life or on TV, unfortunately. But Dr. McKinney, as I listen to you and as I think about other discussions that we've had, especially with primary care physicians that practice in larger metro areas, et cetera, the things that I hear them bemoan is the lack of connectivity, the lack of longevity of relationships, and I almost wonder that practicing in communities such as yours is not just a call back to what primary care has been, but it is almost primary care in its purest form. You are a relationship anchor, not just a healthcare anchor for your community. With the changes in technology, I know Russell asked you about one of the technologies that has the biggest impact. I don't think it was a surprise, candidly, to hear you say open evidence. I mean, they've been everywhere. We've talked to any number of doctors who are using it, and the change, good and are challenging, right? There's both sides of that coin that it's bringing to the practice of medicine. But what have you seen change in terms of how you engage your patients over the last 16 years, either through technology or just the model of care? What's different if you look back 10 years from now to today in terms of what you can do with your patient community?
Well, I think just in the amount of time that I've been practicing, I'll start kind of from the physician perspective that
Yeah.
in order to care for patients, there's so much more paperwork and check boxes. And I'm sure you all have heard that. And that's why tech is so important, right? Because there's so much, and we're talking about the primary care in its purest form. We all went to school to take care of patients, not to fill out forms and check boxes and report things and data, which of course is important. But when we think about why did we go into medicine, it's truly just to take care of patients. So so I would say, the burden of that, just the burden of all the paperwork, everything else is so high for doctors. And then I would just say, the way that we engage with patients is also different because patients also now have access to so much information and it's not always good information, right? It's I don't fault them. I never fault a patient for coming in with like a printout or showing me something on their phone like I found this, like look at this new medicine or I think I have this disease because there's how do they know? I mean, I went to school to find out how to sift through research and evidence and all that to make sure it's the right stuff for my patients. So so it leads to a lot of good discussions and it sometimes turns into most of the visit. Let's talk about what you read and why you think it's this or why it might not be this and how we can help you and how we can kind of redirect or whatever. Or yeah, you're exactly right. Let's go down that route. I'm glad you invested the time to learn about your own health. This is great. Let's do this together and do it even better than if it's just me telling you what you need to know. So the technology piece that's at the hand or the information piece at the hands of all the patients, I think has also been a game changer for better or worse. And it just kind of
Hmm.
it just depends, on the day, on the patient.
Yeah.
And I will say, we've all had to figure out ways to do the work that we want to do. And if you'll allow me, like not really a shameless plug, but to say like we out of necessity, we had to do something different in our clinic. And that was like
Yeah.
way long ago, 2012, I think. I like to say before scribes or technology was even cool, but it was just me and my dad and he was already, oh my gosh, he was already 70 something and he was not about to start learning how to type. I
Yeah.
taught him how to turn on the computer. That was great. And here's a mouse, but he was not about to just sit there and type his notes and check all the boxes and understand what meaningful use was or how to report this data, right? So we had to figure out a way to do it, and that's where it truly was out of necessity. I was actually like mother of a 1-year-old and just seeing every patient that I could because it was two of us. We would see everybody and we didn't have time. I'd be there at 8 in the morning. I would leave at sometimes 7 or 8 at night and I would cry sometimes in between patients, and you just kind of had to figure out something
Yeah.
different. So, yeah, that's how we ended up using remote scribes in our own clinic. And then knowing that that worked really well for us, that I got home at 5 and that I was getting all my work done and I could see my children and actually eat and sleep. Like that was all amazing things that I didn't realize I had the opportunity to do because I was able to do all of that. That's why I created the company to provide that service to whoever wanted to live a better quality of life and just practice medicine and do what we studied to do. So yeah, it's been a whirlwind in the last 16 years and I can't even imagine in my dad's 47 years when he started by writing all the notes on one little index card. So it's been a big change for him too. But yeah, and it's going, we're going to see so many more changes.
It's not stopping. That
Yeah.
the train's moving full speed ahead
Yes.
without a doubt.
Yeah, I was really amazed. I saw it when we were there. I mean, first of all, you know, I saw you teaching documentation. I think you had a student that was there, and you came up and kind of suggested a code or a different way to document something specifically before we went into the patient room. And then I saw you specifically just sit down with the patient with nothing in your hands, and it was this cognitive burden that exists was obviously still in a very small part of your brain. And the rest of it you could dedicate to the patient. The rest of you, at least that's what I saw, you were allowing yourself to connect with them in a way that's very difficult whenever you are thinking through how am I going to code this? How am I going to document this? What do I need to remember whenever I walk out of this room? I felt like a lot of that was off of your plate, for lack of a better term, while you were in the room with the patient. I thought that was amazing.
Thank you. I mean, our brains are kind of already having to think about how we're going to help this patient and also, what preventative needs do they have? How am I going to convince them to take this medication or to change their diet? And so there's a lot rolling around in there it's if we don't have to think about how we're going to document it or how we're going to code it and bill it, like all the better.
Yeah.
Yeah.
One of the things, Dr. McKinney, that stood out as you were describing that is, and I just would say to our audience, it is probably easy to think that in rural communities, whether it's the people who live there or healthcare that is practiced there, that there may be a chasm in terms of technology from what is happening in urban centers or large metropolitan areas, et cetera. And I don't think that's the reality. I mean, as I listen to you, if anything, I feel like I'll just paraphrase, the mother of necessity is the mother of invention. That led to the creation of your company, Remote Scribe, that provides a valuable service. You have community members who are bringing printouts, bringing their phone. I would guess you didn't say it, but I would guess you probably have some now today. They're kind of, hey, the AI told me on my phone that I have this. Is this really what I'm dealing with? And you're dealing with that on a day to day basis. So this probably misbelief that rural communities are technology laggards is not what I feel when I listen to you and other providers that practice. But that being said, the federal government believes that there's opportunities to improve how health and care is delivered in rural communities. They're going to ship $50 billion over 10 years to states. I believe the state of Kansas will get $100 million in 2026 alone to go impact rural care. Now, this is not a political podcast. We're not asking you to opine on politics, good or bad, although I'm sure everybody would be really fascinated to hear your perspective. But I guess really probably my question to you is, where do you think that money for your community could have the best impact to change health outcomes for Fredonians, for those that live outside the city, in the city, et cetera? What are you hoping that money comes and does and impacts your community?
So, it's a great question. Yes, thank you for making the comment about how this is not political because, we
Yeah.
all have these thoughts. But if there are resources to be shared, we are all about it because our communities need this and our patients need this. So if we're thinking about, something different, because that's, the Rural Transformation Grant, we can't do what we're already doing, right? And we can't fund what we're already doing. Probably okay because what we're doing, and I say we, like not putting fault on the rural communities or the rural hospitals or anything, but the government, the payers, everybody, what we are all doing is not working because rural hospitals are still shutting down. We are still so short on workforce, whether it's doctors or nurses or physical therapists or psychiatrists or whatever else. So what we're doing isn't working to provide the best patient care for our patients, especially in rural areas. So if we're being innovative and we're trying to bring new things into rural areas, I kind of am inclined to think about our medical staff meetings every month
Mm,
when we sit down and we look at the finances and where is the money going, like to keep a hospital running, and what are the resources that we're lacking. I mean, payroll probably is one of the biggest, and so I say that in that we still, although payroll is probably the biggest sum of money that goes toward in a rural hospital, we still don't have enough nurses. We're still reaching out to agency nurses and temporary nurses to be able to take care of our patients, and that's even more money going toward that, right? Because it costs a
mhm.
lot to bring somebody in temporarily. So can we somehow use technology to provide the workforce, like for a speech therapist that we don't have? They're in Chanute, they're 30 minutes away, and they only come to Fredonia if we need them, right? So we don't have a psychiatrist that comes to Fredonia. We have some therapists that come, but how can we get more nurses, more respiratory therapists, more speech therapists, more even lab techs and radiology techs? Like,
Mhm.
how technology to maybe not obviously not replace people. We want people. People are at the core of what we do. But if we can't have the people, how can we use technology to take the place of the people that we wish were there, that we would like to have there? So I think that's kind of one of the biggest things. The other thing is when we talk about workforce, as far as my job here at KU Med in rural medicine is to really advance the mission of KU in providing care for all Kansans. And that, with Kansas being so rural, that means that if in an ideal situation, if we achieved our mission, we would have a practicing physician in every community in Kansas. And that is definitely not the case.
Yeah.
So a lot of that though is because people are so isolated. If you were to send, like, luckily I got to go back to my hometown and it was awesome and work with my dad. But if you sent me to, a town that doesn't have any other doctors, and then you're isolated from other physicians, and I mean, really, you're on your own, you're doing all the work by yourself. That, of course, people don't want to do that. You can't do it all on your own. You can't run all the healthcare of the community on your own. Some people do it, and like that's amazing. But if we can use technology to bring together people that are practicing in maybe isolated areas or willing to practice in isolated areas, that can also help support, the idea that we could actually have a practicing physician in every single community. And that means just like being able to connect easily by email, by phone, by whatever it is, and on a real basis, not kind of like cold calling or whatever. It's an awkward thing. We're not connected at this point. So connecting people, improving workforce, and just allowing us to have access to everything that someone would have in an urban area.
Yeah.
my MRI machine. Like if I had access somehow to like maybe an MRI machine other times, or advice from my orthopedic surgeon that maybe knows better than I do about an injury or something. We're not connected. Like we're not connected easily in that
Yeah.
way right now. So those kind of things I think would be great to be able to give us access. I mean, if it's available in an urban area, it should be available in a rural area is my belief, regardless of how much money a hospital has in a rural area. At some point, we have to really invest in rural communities, not just in rural hospitals, but invest in the rural communities. We kind of stopped doing that along the way, and that's making people less healthy in rural. So my thought is always for my children that are 12 and 15, they deserve as good of healthcare as anyone in any zip code in any population size in the entire United States. And if I keep that in mind for the funds that are coming to Kansas, then I think that will guide us really well in what can help rural communities.
So I have a belief, and Russell here in a moment, why don't you just bring us home with the final question? But I have a belief that, um, right or wrong, this money's coming, and I believe that it is actually going to, um, see or incentivize rural communities to go faster in the adoption of, and I say the adoption of technology, not to say that it's not being adopted. We already talked about this. I mean, there's any number of tools that are being used, but the problems that you talked, workforce, either development, enhancement, or putting something in the place of where you can't simply find the people to do the work because of the other macro things are around you. Between workforce, between connectivity, and between engagement and empowering people in those communities to continue to take ownership of the health, I think rural is going to move faster than urban. And I think 2 years from now, as I sit in Kansas City, I'm going to be looking at a community like yours going, we need to adopt that. We need to do those things faster here than inversely what perhaps people have said in prior years. So that's my prognosis. We'll see. We'll see, but I think that's going to happen. Russell, bring us home with one final question.
Yeah. So this one might be it's a little bit different, and it's probably connected to technology tangential. But I've become very interested in um, anthropology of medicine, and how um, what circumstances people are in and how that impacts the way that you treat them. So I'm curious if you have thoughts. How important is it to understand, when a patient walks into your room, the cultural and the socioeconomic conditions that the patient has whenever you care for them? And why is that?
No, I think it's a great question, Russell. And I think we're fortunate to be living in a time and for me to be practicing in a time where we're understanding more how much socioeconomic status and everything else influences a person's health, and we're not focusing on medications or just, different tests and everything else. I have the very great honor of understanding my patients in such an intimate way because they're at the grocery store with me and I see what they're buying, and they're at the ball games with my kids' parents, and I get to see like how they interact with people and what, how they show up in a public setting versus like how people show up in an exam room, which sometimes can be very different, So it's really it's so important to understand who the person is as a whole, what resources they have at home, what their beliefs are, what their status is at home as far as, who lives at home and who do they take care of and who takes care of them and all of that. It's so much, I'd say it's so much more important even than me giving them a blood pressure medication or me, telling them to check their blood sugar, 3 times a day, because those are easy. Like those are easy things. But if I can really dive into saw or I saw, that or I heard that your cousin passed away and I'm reaching out to you, like being proactive. I'm reaching out to you just to see, are you doing okay? Do you want to come in and see me? Can we talk about this? It's a benefit of being in a rural area. Who's hurting, who's thriving, and you can be more proactive about reaching out and not waiting for them to show up in your exam room and I think people appreciate that, just to say I see you, I know what you're going through. I heard this. I hope it's okay if I reach out to you and ask you this, because it's everything. The roof on their heads, the food that they eat, the transportation they can or can't get. That's really what's determining people's health these days.
Yeah,
Wow.
it's like we all have like this narrative in our heads of who we are. And when you go see your doctor, a lot of times that narrative comes out, and whenever you explain your situation to your physician, particularly your primary care physician, you're talking about your life and your circumstances and how your health is impacting those, and how the vice versa, how they're impacting it. And so it's really connected, particularly in primary care. And I think it's a really important topic that we all need to think about.
So as I said earlier, I think Dr. McKinney, you're going to be at the tip of the spear in terms of real, incredibly fast-paced innovation in not just how health and care is delivered, but that is augmented technology because of these funds that are going to flow. People are going to learn, and I believe adopt things that you and other communities like yours are doing in healthcare, which is, I think, can be phenomenal. I would also say my big, hairy, audacious goal is that technology, AI in general, but technology um, gets to the place that it empowers every primary care physician to have a relationship with their patient community the way you have a relationship with your community in Fredonia. And it's hard to replace living in a place for 16 years in a community that probably has a little less turnover than maybe what we experience in a big urban area. But that doesn't mean that we can't aspire to that connection. Dr. McKinney, this has been an incredible conversation. I want to thank you for your time, for sharing your thoughts, your expertise, and your vision for healthcare. Thank you for spending it with Russell and I. And we hope that you have a wonderful day. And we hope we come back maybe a year from now and talk about what is actually impacting rural care from some of these dollars that will flow from the state of Kansas into communities like yours. That would be a pretty cool episode to have.
Yeah, that would be awesome. I definitely think we should do that. We'll see. Who knows what the future holds. But thank you, Doug. Thank you, Russell. It's really an honor to be here and just be able to talk about the things that we do day to day. And it really means a lot. So thank you so much for having me.
Absolutely. Good to see you. Thank you for listening to The Counterweight. We're excited to bring new episodes out, and we are incredibly grateful to our guests and our listeners. We're committed to telling stories of those building and engaging at the intersection of artificial intelligence and healthcare. Let us know what you think by commenting on the episodes. As always, you can find us on Apple Podcasts, Spotify, YouTube, LinkedIn. Subscribe, like, and follow, and we look forward to joining you again next week for another episode of The Counterweight.